So my presentation starts with a stroke code of a 41-year-old female, 38 weeks pregnant, who had acute onset of slurred speech, vomiting, and seizure-like activity. The background was the patient was coming home from her MFM appointment and in the parking lot suddenly had slurred speech, generalized shaking movement that the husband noticed, and then became unresponsive. By the time she reached the ED, she was unresponsive and her pressure had reached as high as 192 systolic. And then she was immediately intubated upon arrival. So her initial mental status exam, and this is after she's been intubated, sedated, and paralyzed. She was intubated, sedated, not responding to any noxious stimuli. She had pupils that were fixed and dilated, no corneals, no oculocephalics, no cough, no gag, and didn't respond to any stimulus. Her initial NIH was 29. So this is her initial CT scan. So it looks like she had a hemorrhage in the right frontal lobe, midline shift, mass effect, vasogenic edema, and some subarachnoid blood as well. So with this presentation and this initial CT scan, there was concern for a vascular malformation. So she was taken emergently to the OR with neurosurgery, and then along with MFM and the neonatal team as well for the baby. She had a hematoma evacuation, hemicraniotomy, and then they found a large right R1 aneurysm that was actively bleeding that they clipped. And then during the surgery, they also delivered the baby via emergency section. So post-op, her exam didn't significantly improve. She was intubated, her right pupil was 5, left was 3, so anosacoric, non-reactive, no other cranial nerves, no corneals, no cough, no gag. She had some flexion in the bilateral lowers, some maybe questionable withdrawal in the right upper, and then left upper extension. Several days after this exam, she unfortunately passed. And then the baby who was delivered in the OR initially had APGARs of 11011. So the baby eventually had code event, was intubated, and taken to the neonatal ICU for hypothermic protocol. Currently, the baby is actually doing really well, extubated, has a reassuring neuro exam, and the MRI brain, which they did, was negative for HIE. So my topic is CVA complications during pregnancy. So is there actually an increased risk for vascular malformation rupture during pregnancy? Actually, the Neurology Continuum article for this month is on pregnancy, and they talk about vascular malformations. So there's two main ones that they talk about, AVMs and aneurysms. They found that AVMs, once they did a 2021 study, shows that there is an increased risk during pregnancy for AVM rupture. Versus aneurysms, they did a systematic review of studies done in the past, and they found that there isn't an increased risk of aneurysm rupture from pregnant women compared to the general population. However, if there is to be a rupture, it's most commonly during the 3rd trimester. There was an additional observational study done where 5 women were followed who had aneurysms and were pregnant. 4 of the 5 did not have any change in their aneurysm. The 5th one had an initial increase, and then it returned back to its normal size after delivery. And one of the other things to mention is, when do you treat an aneurysm versus when it's symptomatic versus unruptured, ruptured? It's a little bit controversial, but I found from data about 7 to 10 millimeters is when they start thinking about treatment, unless they're already symptomatic at a smaller size. And outcomes wise, from the guidelines, it shows that pregnancy-associated hemorrhage stroke are about 50% fatal and has a significantly increased risk in maternal mortality. And that's all I have.
Thank you very much.
Yeah,
great job.
absolutely.
And a very sad case. All right. Continue. Here we are. All right, so today's Grand Round speaker is Dr. Stan Appel, who's had, if you look at his CV, just a remarkable career, but he definitely peaked in the years 1969 to 1977 when he was chief of the Division of Neurology at Duke. Will, what year is this photo from? I think he told me 75.
75, yeah.
And standing next to him, in desperate need of a haircut, is Alan Roses. What a powerhouse. I don't know who any of the other people in the photo are, but we'll try to get them all identified. I'm sure you know, Dr.
Stedman?
We'll get that all run down. But anyway, it's my honor to introduce Dr. Appel today. This is where the COVID hurts. I think there's been a lot about Grand Rounds and Zoom that have made things better in the COVID pandemic, but not today. I was really desperate to bring Dr. Appel back to Duke. But with COVID hopefully on the decline, we'll be able to do that in the not too distant future. Reviewing Dr. Appel's CV is both intimidating and awe-inspiring. It's the biography of a life devoted to the field of neurology, his scientific work, his trainees, and his patients. One can only imagine Duke Neurology in 2022 if Duke Medical School had established a Department of Neurology in 1977 in order to keep Dr. Appel here. Dr. Appel was born in Boston, Massachusetts, and graduated from Boston Latin, famous for producing scholars and not hockey players. Other famous graduates include Benjamin Franklin and Leonard Bernstein. He then went to Harvard, got his MD at Columbia, came back to Boston to intern at the Mass General. And then from reading his CV, it looks like he did his neurology residency in 3 separate places: Penn, Mount Sinai, and Duke. He joined the faculty at Duke in 1967, and by 1977 was the James Buchanan Duke Professor of Medicine, and had been the chief of the neurology division for 8 years by that time. In 1977, he moved to Baylor as professor and chairman of the Department of Neurology until 2004. He was succeeded at that point by the person to his left, Dr. Alan Roses. In 2004, Dr. Appel moved across the street from Baylor to Methodist Hospital after the schism between Baylor and Methodist, a very important lesson for us all in these eras of alignment and acrimony at Duke, that catastrophes can happen. From 2005 to 2015, he was the chair of the Department of Neurology at Houston Methodist, a department that is now named after him. He is currently the Peggy and Gary Edwards Distinguished Endowed Chair in ALS Research in the Stanley Appel Department of Neurology. He's also the director of the Ann Kimball and John Johnson Center for Cellular Therapeutics and the director of the MDA and ALS Research and Clinical Center at Houston Methodist. He was past director of the Baylor ADRC, the Alzheimer's Disease Research Center, which we have recently acquired here at Duke, which makes him one of the few neuromuscular dementia crossover people, preceding the understanding that ALS was in fact a neurodegenerative brain disease. He's been the chair of the ALS Society of America, the Medical Advisory Committee of the Muscular Dystrophy Association, and chairman of the National Scientific Council of the National Huntington's Disease Association. He has 458 publications on PubMed over 62 years. The first, and perhaps most interesting, is a 1959 paper in The Lancet about non-conforming nerve cells, a satirical response to an article written by the estimable John Menkes, who was describing silent neurons in the lateral geniculate nucleus and their potential role in visual function. His most recent paper was in the Annals of Neurology in 2021. Interestingly, Dr. Appel has 23 papers with Alan Roses, many of them on myotonic dystrophy and Duchenne muscular dystrophy. We're honored to have Dr. Appel with us, at least by Zoom today. The title of his talk is Suppressing Neuroinflammation, Treg Cell Therapy and Neurodegenerative Diseases. And for the whole department, Dr. Appel, we welcome you back to Duke, at least by Zoom.
So I'm going to try and share my screen if I can.
Sure, yeah. I'm looking forward to it.
Thank you, Rich. That was very much appreciated. I just have my own smaller version. This is from 71. It doesn't have Jim McNamara, who was in the other one, but it had Al Heyman and myself. And here's the unforgettable and fabulous Alan Roses. Notice the only one with a beard and the only one smoking a pipe at the same time. All of you remember Al fondly, Alan, as I did. A great leader and a wonderful character, to say the least. We miss him very much. From my perspective, I'd like to discuss the focus that we've had for the last several decades on neuroinflammation and why it may be an important approach, not just an understanding what's going on at a basic science level, but as well an approach to a therapy for ALS and even for Alzheimer's as well. My disclosures, a small company is formed which licensed a lot of what we're going to talk about from Methodist Hospital. So here we have the three diseases, and in our hands, regulatory T cells, lymphocytes, appear to be an approach that we think is very meaningful for these three diseases, whether it be Hawking, Muhammad Ali, or President Reagan. All three are representative of dramatic enhancement of neuroinflammation. So does neuroinflammation start the process? So am I talking about these as autoimmune diseases? And the answer is no, but neuroinflammation is in fact propagating neuronal injury as a result of signaling from neurons to glia and the immune system. And this is the process that becomes the major definitive way that these diseases spread. So what's the evidence that it contributes? Whenever you ask for evidence, you've got to have immutable evidence. Oh, it's from mutable genes, because mutant genes linked to ALS provide the most compelling evidence that the immune system is involved in disease pathogenesis. Here's just a list of the few, and these, for example, optoneuron, in fact, can be dramatically increased in macrophages, microglia, and will drive the inflammatory process, as will C9, ORF72, SOD, fractalkine, etc. But here's the evidence that we have from our point of view that regulatory T cells are playing a role. What we did is we crossed a good number of years ago the mutant SOD mouse with a RAG2 knockout, which takes out the immune system, or a CD4 knockout. And this told us that we were removing the immune system, and more specifically CD4 T cells. And when we did that, there was a dramatic increase in inflammation marked by macrophages, microglia, gamma interferon, Th1s, and the animals died earlier That was the big surprise. We expected that when we take these immune cells out of the system, that the animals would live longer. The T cells were contributing in a way such that if you remove them, the animals did better. The opposite occurred, and that's the start of our journey. Because when we put back specific subpopulations, only the population of regulatory T lymphocytes, in fact, enhanced survival in the mouse. It decreased the pro-inflammatory myeloid cells, gamma interferon, and increased the anti-inflammatory myeloid cells, Th2, and the animals lived 88% longer. We then went to man in ALS, and we had a simple model. The model was that regulatory T cells, the neuroprotective T cells, with the transcriptional factor of FOXP3, suppress activated Th1s and Th17s. They don't suppress activated macrophages in their native form or even when they're circulating. But what happens when the activated macrophages are dramatically pro-inflammatory, you downregulate FOXP3, dysfunctional regulatory T cells, and they're no longer suppressive, and you have a pro-inflammatory milieu. So that's the cartoon model. We then went to man, and we documented that Treg suppression, and there are two particular parts of the suppression. One is Tregs suppress activated Th1s and Th17s, namely T cells, but they also suppress activated myeloid cells. And if you've got increased suppression, then you have decreased burden of disease, and you have slower rate of progression of the disease. So Tregs are influencing in patients both the burden of disease and the progression rate. But we also documented if we take at one moment in time and look at patients that have very, very low levels of Tregs because of the pro-inflammatory milieu, 3 years later, 35% of those patients are dead. Whereas if they have a high level, only 13% are dead. So in fact, the Treg suppressive function was dictating survival as well as burden of disease and rate of progression. So we then said, well, look, if in fact the myeloid cells are unhealthy Tregs, converting them into dysfunctional Tregs, which no longer can suppress, and these in turn can release gamma interferon and TNF alpha to make this more pro-inflammatory, how can we change this system? And the way we looked at changing this system was, let's take them out of the body, let's expand them and look at them, and we can genetically reprogram them. So we took them out of the body and expanded them ex vivo, and without having to reprogram them, just removing them from the inflammatory milieu resulted in their abilities to suppress pro-inflammatory myeloid cells and T cells. And I've just listed a number of mechanisms that we've published whereby you can suppress these pro-inflammatory myeloid cells and even Th1 and Th17. So with that as a start, we said, look, this is something we can possibly use in a study of patients. Before we did, we wanted to look at the proteomic profile of these cells. Were the expanded cells the same as the cells we took out of the patient before expansion? And the answer was no. Here you see the proteomic profile where we found there were 3 general populations. Population 1 was increased in baseline, and it consists of methylation, oxidative stress, and innate and adaptive immune signaling, which were downregulated, fortunately, in the expanded cells. Population 2 was dramatically increased in the expanded cells, and these were expanded cells frozen and thawed. These were expanded cells, and we needed to do that so we could ship these to our colleagues that we were collaborating with. These enhanced mitochondrial health. But the most interesting set were ones in which we had a downregulation in the baseline Tregs and expansion of all the markers that enhance the Treg suppressive function. So these are all particular molecules that we knew enhanced them. And when we in fact thought about infusing them, here's the problem. Everyone said at the time, well, why don't you just sort of immunosuppress the patients and that will help? The problem is if the Th1s and M1s are outstripping the Tregs, which are dysfunctional, and you've got this dramatic imbalance, if you immunosuppress, you take the whole system down. You don't change the ratio of bad guys to good guys. So in fact, what we've got to do is change the ratio. And the way we decided to change the ratio is to add the expanded anti-inflammatory Tregs to the patients intravenously. So far, we've said that regulatory T lymphocytes are dysfunctional. They're not suppressive, but when they're expanded, they're enhanced. And the question is, can it provide any therapeutic benefit for patients? So here are 3 patients that we studied, one going at an intermediate rate with an arm onset, one with bulbar onset that was going very quickly, and one, a nurse that had leg onset and she was moving slowly. And we administered their own cells. These were autologous infusions that we got FDA approval for. And we found that we could enhance the suppression in the patient here. Here's the suppressive function here, the number of these cells. We did it weekly, and then we did it subsequently monthly in all 3 patients. And here's what the ALSFR Treg showed. This was a study that was led by a person who was our chief resident, who then joined my lab and then the faculty, where we found that we could stop the progression of disease. But the problem was it was only every 2 weeks. And when you use the ALS-FRS every 2 weeks, you might have a placebo effect in there. But at the time, it looked extremely promising. So we administered these, but then the problem was when we stopped, the effect didn't last. The patients fell off the mountain. We then went back in and we did it monthly, and we stopped progression in all 3, which was exciting to us because it said the Tregs are doing something. But were the Tregs doing something? Why didn't the effect last? And at the time, we didn't understand it. And now I think we do understand why. So here's an overall expression of neuroinflammation for you to think about. Let's talk about 2 different compartments. A CNS compartment in which you've got activated microglia, macrophages have entered, NK cells, T cells, astrocytes are pro-inflammatory. And you've got 3 kinds of death. Apoptotic cell death, which is the one we're always thinking about, necroptic cell death, and that necroptosis is primarily inflammatory mediated. This is fast and fast ligand. But I want to call your attention to a 3rd type of cell death that we don't talk about too much, but is critically important in neurodegenerative disease called ferroptosis. That's where mitochondria have an alteration that results in the release of lipid peroxides. Now, in addition, in ALS, there's a dramatic increase in inflammation peripherally, systemically, and it's manifest at the nerve terminal in a study we did a number of years ago that showed dramatic increase in calcium in the mitochondria of the synaptic terminal of patients with ALS. This was done by a fabulous neuroscientist, physicist from Hungary named Laszlo Siklos, Joseph Engelhardt, working with us, who documented calcium uptake at an ultrastructural level. And this is outside the blood-brain barrier. I'll show you data that acute phase proteins coming from the liver are enhanced, and the gut microbiome is also enhanced. So you have both inflammation in the CNS compartment, but you have inflammation in a peripheral compartment as well that is contributing. So let's look at that in a little more detail. Here's a control nerve terminal, presynaptic terminal, showing the beautiful configuration, and you don't have a dramatic increase in calcium. But here's an ALS terminal, and here you see the dramatic increase in calcium. The mitochondria do not look healthy, and you've got increased calcium throughout. And here's another example of the same thing. Here's a patient with neuropathy showing the Schwann cell envelopment, very different from ALS that has mitochondrial division, and they're on their way down with, once again, dramatic increase in calcium throughout. This study we did many years ago, but now that ferroptosis is becoming real with mitochondria and iron concerned, we've gone back and looked at these, and these were very relevant at that time and still now, almost specific for ALS. Now, here's what we're talking about in a model. Under normal circumstances, you have some calcium entering. The calcium results in some increased release of reactive oxygen species, but it's in a balance such that ATP is increased and you have an antioxidant response. But if you have this dramatic increase in calcium, then you end up with dramatic increases in reactive oxygen species, oxidative stress, and oxidative stress mediated ferroptosis, which we submit is something going on in neurodegenerative disease and especially in ALS. So here's what's going on. Calcium is coming in, activating phospholipase. You're taking arachidonic acid, and in the presence of iron, you're converting it to lipid peroxide, 4-hydroxynonenal, and we've published on several occasions dramatic increase in 4-hydroxynonenal in the spinal fluid in the blood of patients with ALS. So here are the biomarkers, but it is important to consider these biomarkers. Here's soluble CD14, and this is one of the definite APPs that's correlating. Here's another one. Here's lipopolysaccharide binding protein, a liver. This is fast progressing ALS, slow progressing compared to controls. But here's the one that I want to focus on for the moment: oxidized lipopolysaccharide, oxidized LDL, low density lipoprotein. And here's the correlation between progression rate and oxidized LDL. So this is affecting our patients. So we went back and looked at our patients from phase 1. Here's patient number 1. Here's oxidized LDL. Here are the infusions of the Tregs. and the Treg infusion are suppressing the oxidized. Here's when we stopped and there's an increase in oxidized LDL. Here's when we went back on a monthly basis in the patient 1. This is the ALS FRS in the patients, stop progression, enhance progression, and stop progression again, correlating beautifully with the suppression of oxidized LDL by Tregs. Here's patient number 2 with the same thing, suppression, stopping suppression, correlating with progression and suppression again. Here's patient number 3. Even though the patient is not progressing as fast, the same thing holds. So it's quite clear, if we look at these, that one of the explanations for which the patients are falling off the mountain is that Tregs are suppressing oxidized LDL, and when it's not suppressing, under those circumstances, the oxidized LDL is going up. So the Treg neuroprotective functions are compromised. Phase 1 study was safe and well tolerated, but the study was of short duration, only 3 patients, and the clinical benefit was limited by the increased oxidative stress on Tregs. I will tell you, we've just completed a phase 2A study, and it's being reviewed for publication. In 12 patients, unfortunately, COVID-19 reduced the patient enrollment, and we did this in collaboration with our colleagues at Mass General, at Harvard, with James Berry at Meritz-Covich, and hopefully this will be published soon, and gave very promising results, and we're now planning a very large placebo-controlled double-blind study. So let me come back and let's look at the other disease that I want to focus on for the moment, Alzheimer's disease. So in Alzheimer's disease, inflammation is a core feature of pathology. Here you see amyloid plaques, which are very important, neurofibrillary tangles, the tau, and these collectively are causing microglial activation and inflammation with neuronal loss, synapse alterations, and symptomatology. Now, the same thing holds there. What's the really definitive evidence that neuroinflammation plays a role? And almost 2/3 of the Alzheimer's risk genes are exclusively expressed by microglia. And this has been well documented by a number of groups. So this is telling us once again that genetic approaches, GWAS studies, indicate that inflammation is important. Okay, well, let's look at this. Well, the same thing holds there. M1 altering Tregs, dysfunctional Tregs, and Th117. But when we expand them, we normalize them and we enhance this. So here are some indications that we've published of what happens with the gene expression of the expanded Tregs compared to baseline Tregs. And here are a number. CD25 is the interleukin-2 receptor. Here's CD73 that converts ATP ultimately into AMP and cyclic AMP. Here's granzyme B. And so all of these change compared to the baseline, exactly similar to what we found in ALS. But here shows you the suppression. If we look at the suppression of Treg proliferation under baseline circumstances, it's relatively in the 20 to 40%. But when we expand them, we normalize. These are dramatically increased suppression of these. So the same thing holds in Alzheimer's. And I'll tell you, we've also published recently in Parkinson's, the expansion results in enhanced suppressive function. So this is just to show you that they don't suppress M1s. This is interleukin-6. the expression in the RNA. Here's the interleukin-6 protein. And when you expand the cells, you remarkably suppress both the protein and the gene expression of TNF-alpha and interleukin-6, as well for interleukin-1 beta. So compromised Tregs, mechanisms in AD patients, AD Treg suppressive function is restored, and there's a potential impact on expansive Tregs. So how are we going to approach this? Well, we approach this in a slightly different way, and that's what I want to describe for Alzheimer's that we're very excited about. I talked about ALS, whereby you take the cells out and you expand them in a GMP facility, very expensive, but it is a definitive way to get expanded, normalized Tregs into patients to stop suppression or to enhance suppression of T cells. But there's another way to think about doing it. What about giving patients themselves injections that might enhance in vivo? And that's studies that were carried out by another one of our chief residents who joined our group and is now in the faculty, Ali Faridar, and show you some of his data. So when we did this in patients, this is where we started. We gave subcutaneous infusions and we enhanced Tregs, but it only lasted for a week or so. And then it dropped back down at day 30. We did it again, only last. We did it again, enhanced it again. So the Treg numbers are going up. And here's what's happening to the interleukin-2 receptors. This is, the MFI is measuring the interleukin-2 receptors per cell by flow. And we see that it's following this same, it's monitoring the number of T cells, increasing the expression of the interleukin-2. But when we in fact look at the suppressive function, it went up, went down a little bit, went up, but then it stayed up. It stayed up. And so we have had enhanced suppression, but when we stop, it's coming down again and return to baseline. But here's the critical experiment that we love. We were suppressing interleukin-1 beta expression of the myeloid cells, as well as suppressing TNF-alpha, as well as suppressing interleukin-6. So we were suppressing inflammation in myeloid cells. And here we had one patient, and I'm not sure this is going to hold for everyone, but here is monitoring glial activation in vivo with PET scanning with 11-CER176 to show that we were suppressing the inflammatory response of microglia. Very, very exciting. So not just taking the cells out and showing what they're expressing, but this is in vivo with PET scanning in patients. But here's the pièce de résistance. Here's what happened in the MMSE score. It went up and stayed up. In fact, the patients did better. It didn't slow the deterioration, it enhanced function. And here's our Treg suppression correlating with the MMSE. So we're very excited by these promising results. And in point of fact, we were given the opportunity to submit a grant to the Alzheimer's Association and the Gates Foundation, and they have given us a very large grant to do a phase 2A double-blind placebo-controlled trial of this to see if this really works. And we're very excited about this possibility. So in Alzheimer's, the Treg immunomodulatory function is compromised. there's an impairment in Treg population, which is contributing to AD progression. The Tregs are modifiable therapeutic targets, and we had promising results in restoring dysfunctional Treg in a phase 1 feasibility study in 8 patients with AD. And we now have in process a phase 2A proof of concept, double-blind, randomized, placebo-controlled study that is now been funded, and it's going to be a 40-patient study. And we have now over 15 patients already enrolled, safe. All of these studies that we've done, fortunately, are safe and well tolerated, and it remains to be seen if we can prove this in double-blind studies. Well, I've gone over a lot of data very quickly, but I want to leave you with some final thoughts. Neuroinflammation, a major determinant of disease pathogenesis, not an initiating of disease, but a determinant of the rate of progression, of the burden of disease and survival in ALS, PD, and AD. The Tregs are dysfunctional. They promote increased disease burden and progression, and ex vivo expansion restores suppressive function and is the basis of novel therapies that we're engaged in. In ALS, autologous infusions were safe, well tolerated in a phase 1 study, and we've just completed our 2A study, and Tregs effectively suppress T effector proliferation and pro-inflammatory myeloid cytokine release. I might comment, when people talk about suppressive function, they mainly and solely talk about T cell proliferation, but in our studies, we're talking about both. And we think it's a suppression of the myeloid, the macrophages, the microglia, et cetera. They're a most critical component of the Treg neuroprotective function. In open label studies, the clinical benefit is predicted by the Treg suppressive function, and the markers of oxidative stress respond to Treg suppression. And we have a large randomized double-blind placebo-controlled on the dockets to really determine if this will hold over the long run. In Alzheimer's disease, in vivo expansion of the Tregs increases Treg numbers and Treg suppressive function, not just of T cells, but of myeloid pro-inflammatory cytokine expression. And an 8-patient open label study improved clinical status, and large double-blind placebo-controlled study is in progress. Well, we think that T regulatory platform is a game changer. And I'll just close in thanking Rich for the opportunity to come back to Zoom, through Zoom to Duke. I was weaned here, loved my life there. My kids grew up there. My family grew up there. My son is a sports lawyer because of being growing up in Duke, involved in, and all of us love the community, a great community, and we miss you all very much. Thanks for the opportunity, Rich, and I'd be happy to address any questions.
Thanks, Stan, and I'll orchestrate the questions from the chat, and you and I will be talking later. I just have a quick question. Why is there not a dash between the T and the regs? Because it looks like Tregs.
We call them Tregs, it's easier. There's no dash.
Oh, interesting.
It's a slow compound rather than a 100-meter.
All righty. Don Sanders, you're first.
Stan, last time you and I were together, we discussed some findings that Janice Massey noted a number of years ago, that the earliest physiologic electrodiagnostic abnormality in pre-symptomatic muscles in ALS patients was increased jitter. I don't know if this is still something that you're thinking about, but I wonder if it would be worthwhile in future studies, clinical trials in ALS, that it would be useful to measure jitter serially as one of your potential biomarkers. And Janice, if you're online, you can correct me if I'm misquoting you.
Well, Don, great question. And I would have said 5 years ago, no, I don't think so, when you and I may have first chatted. But the more I keep staring at the studies we did, even in muscles that look strong, from ALS patients that had the presynaptic alterations of the mitochondria, increased calcium there is no question that if we were looking at those physiologically, we would have increased jitter there. So I think you're right on. I think the more I think about it, I'm one of the believers that this is a bottom-up process in ALS. It starts at the neuromuscular junction with a dying back. You know, there's a school of thought out on the West Coast that says it's a top-down. It starts in the brain, from John Rabbit's work, et cetera. I'm not a believer of that. We think, and we just published a paper that 3/4 of the patients start with a dying back. So I think you're right on. I would ask another question, which is, if we could suppress the reactive oxygen species, if we really had effective free radical scavengers that could block lipid peroxidation, that would be the correlation I'd love to see with the jitter. That combination would be really important. So I agree totally.
My memory is, Stan, that you were the one during that conversation that convinced me.
Oh, okay. Well, you're now convincing me again, Don.
It's a closed loop.
Yeah.
Rick Bedlack?
Hey, thanks so much, Stan. As you know, I'm a huge fan of this work. One question I had, might it be possible, maybe even more feasible for real world use, to try to manipulate these Tregs by changing the microbiome, possibly with a probiotic, for example?
Well, Rick, you're right on target. I think we'd love to have that. There is no question that the gut microbiome is contributing. The question is it way upstream or is it downstream? Is it very late in the process? And that's the issue. There is no question that if we could suppress all the fatty acids that are coming out of the microbiome that are dictating inflammatory processes, we could suppress that, we'd find out whether it's way upstream or downstream. No question, you're right on target. It's making a contribution. The question is, how can we deal with that effectively therapeutically? For those of us who are clinician scientists, the real answer to the question is not what can you document preclinically, it's what therapeutics can you come up with that target what we want to target and will be effective. And you're right on. No question, gut microbiome is going to play a role in all of these diseases.
Nicole Kalakos?
Hi, Dr. Appel. Really great talk. Two questions now, just responding to what you were just saying. Are you familiar with the ISRIB work and the proteostasis pathway, the ISR? When I saw the really marked proteomic shifts between when the Tregs were inside the body versus outside the body, you think about just changing a proteostatic state, which predicts then when it gets back in the inflammatory host, it'll go back. So I guess ISRIB's being tested in all three of those diseases, ALS, PD, and AD, to just change the cell stress response.
Well, right on. There is no question that proteostasis is playing a role. But if you step away for a moment, the question is, how are we going to deal with this therapeutically? That's to me the issue. Which of the proteins are you going to target? If you target a single protein and downregulate it, we really don't have evidence, even in familial cases where it's likely a single protein, that stopping that is going to stop the disease. We think it will. We're excited about the SOD, antisense oligonucleotide, the C9orf, et cetera. But it remains to be proven that these, when you decrease these proteins, that you shut off the process entirely. I'm optimistic that we're going to help there, but it remains to be determined. So for that reason, it's not that I'm not a fan of proteostasis. It's clearly going on. I'm challenging everyone, as they challenged us, come up with a therapeutic that works on that mechanism per se, and we'll accept it as the definitive answer.
And the other one is just a practical question. I was curious, can you educate me about the approximate half-life of these particular Treg cells? I saw some in vivo data suggesting at least inflammation was suppressed about 3 months. And can you help me think about the turnover of the Tregs and what you're anticipating in terms of the perpetuation of this effect or the frequency of this needing to reduce cells?
Rich, that's what I love about Duke. The questions are wonderful questions that you can't bat out of the ballpark. They're questions that really deal with real life. Nicole, that's a great question. So number one, if you were to anticipate putting in a T lymphocyte of any sort, including a regulatory T lymphocyte, you figure the half-life would be 1 or 2 weeks at best. No question. So what we're talking about is not necessarily the half-life of the cell, it's the half-life of the functional effect, which then means the cell modulates, let's say, a monocyte, converts it from a pro-inflammatory into an anti-inflammatory, at least pushes it in that direction. Now we can ask, what's the half-life of that functional suppression of that? And so what we have found is, if you would go back in the data from the 3 patients, they told us almost everything. The slow-moving patient who got the Tregs, the woman who got the Tregs, her benefit lasted 6 months before there was any evidence that she was beginning to deteriorate. The very fast-moving patient went 2 weeks, and the intermediate went about a month and a half. So there is my answer, that it's the functional effect of the Tregs and the whole milieu that you're changing, rather than any single cellular constituent that you can look at that's dictating the half-life of the effect clinically.
Super, thank you.
Thanks, Nicole. Kevin Van Landingham.
Yeah, thanks, Rich. Stan, great talk. Have you seen in the slow ALS patients a longer treatment period or increasing Tregs that's resulted in sustained improvement, or do you think it's a different etiology?
No, I don't think it's a different etiology, but that's why I showed you the first study we did, and I was just talking, my answer to Nicole, that patient went 6 months after we infused the Treg. Now, one could argue, so that in essence, she was a slow mover with far less oxidative stress. But you can ask the question, well, what would have happened if you hadn't given Tregs at all? And that's the problem. So unless we do very large studies, which are so expensive when you have to expand the cells in a GMP facility that costs between $100,000 and $200,000 per year, et cetera, difficult to get a definitive answer to any of these questions unless you go long periods. But our in vivo enhancement may begin to ask that. Now, I agree completely that the slow patients and we have data that, in fact, as I've shown you, that say if the patient's going slow, the oxidative stress, the APPs are in fact are a lower level compared to patients going fast where they're dramatically increased. So that begins to speak of that, but we're only going to get a definitive answer when we do very large studies in a way that are blinded and all of us would accept this.
Thank you. Janice? Janice had a question. I assume it's Janice. It could be Jim McNamara too. I'll read it. iPhone JM says, I continue to question clinically about the various patterns, and some seem to be predictive of temporal pattern of progression. Any thoughts?
I'm not sure. Every time Jim, if that's Jim McNamara, when Jim asked me a question.
No, I think it's Janice.
Oh, Janice. Well,
Yeah.
maybe Janice as well. Jim McNamara is one of my heroes. So Janice, I'm sure you're in that same category. So there's no question, at least obviously, when you look at a population of progression in ALS, it's all over the map. We know that it can go at varying rates in different patients, which is why it's almost impossible to predict the future. So is there any correlation between these and the inflammatory markers? And the answer seems to be yes, with respect to cytokines such as interleukin-1 beta, TNF alpha, gamma interferon. But in our hands, it looks like there's a better correlation with reactive oxygen species, but it also is monitoring the temporal progression. Now, the interesting thing is there's a very definite loop feedback. If you take a microglia, it will release increased cytokines in the presence of stress. If in fact you stress it with oxidized reactive oxygen species, it will do the same thing. So they feed on one another. Reactive oxygen species gives rise to inflammation in the same cell, namely myeloid cells, and in turn, the cytokines give rise to increased oxidative stress. So yes, these are going on, and we think there's a correlation, but it is not 100%, and that's the difficulty, and that's the variation in immune presence and function in these patients, as well as in clinical rate of progression.
All right, that's it from the folks. I'll just end with one last question, and then you and I will be chatting at 9:30. What about ApoE? You can't have a theory of Alzheimer's without, especially being a Duke alum, and not have ApoE be part of it.
Well, I will just say two things. One, Warren Strittmatter did gorgeous work on ApoE when he was here with us in Houston. But then, of course, went back to Duke, and he and Alan Roses did the definitive work on ApoE. So big fan of ApoE. And I think most of the data would say not only is it important in dictating the rate at which beta amyloid leaves, but ApoE is a critical component of the myeloid, the microglia, the macrophages, and the way in which they digest beta amyloid, et cetera. So yes, ApoE is part, but it's a major contributor to the inflammatory milieu that's dictating rate of progression in Alzheimer's disease. No question.
All right, well, thank you so much. You've been away from Boston for 60 years and you still have an accent, I have to say. I could hear it. I don't know if anyone else could.
That off
Rich,
mic.
I still park my car in the Harvard yard.
All right, I'll be chatting with you at 9:30, and thank you so much, and we'll get you out here soon.
All right. Great. Thanks for the opportunity. Always wonderful to return to Duke. Rick, nice to see you again.
Great to see you, Stan.
Yeah.
Take care.
Don, same to you as well, my friend.
Yeah, thanks a lot, Stan.